Video I will be talking about a few of the stations. Station is for communication station, and this is communication by the phone call. So what is the task given? It can be you are a ST3 registrar or SHO or a doctor who was called either by a nurse or you have attended a patient, and now you need it to inform respect to a particular consultant, a task. So there can be different situations. So what can be the scenarios and which patients you have examined? There can be around 6 to 7 different situations for which what things you should keep in mind and how this station has to be done. And it is that there is S-bar. S-bar is you understand the situation, you get the background, then you assess the situation, and then you recommend or use the situation. It has to be covered following points. So this is generally a phone call. You have to pick and call to the consultant, the respective doctor. So for this you have to understand the situation. Situation means that once you check the patient, it's you have to inform your own identity, who you are and which hospital you belong to, which ward you are attending the patient, and then you are talking about the patient, which patient, what is the age of the patient, and which hospital the patient is admitted, under whom you are working. And then once you understand the situation, that why you are calling the respective doctor, means it may be the cardiothoracic consultant, or am I calling to the same concerned doctor, is it, that has to be checked. So all these things are to be picked out from the case paper. So B is the background, why this situation has arrived, means this should include what is the history of the patient in short, when the patient is admitted, in which hospital, and why the patient has become critical, or patient needs some reference, or patient needs some opinion or something. It is concerned with the background. What is the background of this call, why you are making this call, and what is the background. So background means why this situation has happened. So that should include the short history of the patient, from where the patient was referred and when the patient was admitted in the hospital, and what things has happened, what are the doctors who has seen it, and what investigations. So then third part is the assess. What is BAR? So what things you are assessed, means what is the present condition, what is blood pressure, pulse, respiration, findings, vitals, then what blood investigations, what radiological investigations, who are the concerned doctors who have seen it. So and what things you yourself have checked, means after your personal assessment, you have a case paper, you have read everything, and what things are to be done, that everything. So you have assessed this, then what is your response, so what you expect to do. And that's why you have made a call. Either it can be to a cardiothoracic surgeon, or a hepatobiliary surgeon, or a consultant, or the in charge. So in this way the S-bar is to be completed. Now what are the different scenarios in which you get this type of S-bar station? Commonly things are the post-mastectomy. A patient has undergone mastectomy. This is so and so old lady having COPD or something, then left ventricular failure. This may be third day, fourth day, and then patient has been put a drain. Then you have gone through all the case reports, findings, and everything. But the patient's daughter, old lady is there. The daughter is insisting to go to the home or something, but you feel that the drain is having little bit. So now you are making call to the consultant and informing that this patient is asking to get discharged. Another situation can be a patient, you have to understand from the starting papers only. Patient undergone cholecystectomy 2-3 days back, drain was put, and initially the drain was this and cholecystectomy unfold, and then what you have done after doing cholecystectomy, first day drain was this one, now the drain has little bit bilious discharge. Now you are suspecting something wrong has happened, it can be this or that. Now you are making, your consultant has seen the patient, all radiological investigation, blood investigation, everything is done. Now the decision has been made that this patient may be having bile leak or something and needs to be referred to a hepatobiliary surgeon. So now you are making call to the hepatobiliary surgeon. Another situation can arise that a road traffic accident, a patient has a motorbike accident or any road traffic accident who has been admitted in an emergency ward, and immediately what you see, chest x-ray is done, CT scan or something is done or not, but chest x-ray shown the widened mediastinum, the patient is in very critical condition, patient is having maybe multiple injuries anywhere, maybe head injury, maybe abdomen injury, maybe anything, but chest x-ray has shown that the patient has widened mediastinum. So among these, the situation has arrived that this patient had road traffic accident. The background is that this patient is getting critical, assessment is done, patient is becoming bad. Irrespective of other abnormalities, your consultant and or the team has decided that this patient may be having some injury to the great vessel. That's why this patient needs urgent referral to the cardiothoracic surgeon. That's why you are making call to CVTS cardiothoracic surgeon, informing that this patient is about to be shifted to your unit in a very urgent manner. So this patient having multiple polytrauma accident and all that, abdominal injury, this and that, and the patient has developed something like any limb is becoming pale, pulseless and something. Now you are thinking that this patient needs to be informed to the consultant ahead of the trauma unit and update the case. So that is updation. That a patient has undergone laparotomy, surgery is done, and then after surgery, maybe 2-3 days, patient develops some cardiac problem, atrial fibrillation or something, and after that fibrillation, you feel that the limb has become pale, pulseless and all that. This has become a limb issue, and now you are consulting to a cardiothoracic or cardiovascular thoracic surgeon that there is chances of losing the limb. So there can be another situation in which a patient is very old, alcoholic, smoker, COPD, heart problem, diabetes, multiple diseases are involved, and patient has a steroids history, and now you are suspecting that patient has taken the steroids and there is perforation of the viscus, and patient may go in septicemia, and this patient may need a surgery, and after doing surgery this patient may require intensive therapy or high dependency unit to ITU register. So you are asked to call to the ITU register to just make an arrangement to pre-operative checkup, as well as make a hospital bed available, keep the hospital bed available for this patient. So these are the different situations where you are reading a scenario, then you get 9 minutes, you are checking it, then you have to pick a phone and ring that. So what are the specific things you have to remember in this is, it's S bar. So S bar is, first of all, you have to introduce yourself, your name, your grade, and then clarify whom you are speaking, and then basic details of the patient and where is the patient present at present, and then what is the timing this current problem started, and why you are referring to the or making a call. So it has to be in a very single sentence. Hello, myself Dr. Hamid, one of the surgical doctors, and I am working under this hospital, any share hospital, under Mr. Mann as a consultant, and I have checked a patient named Miss Linda Smith, and she is 60 years old. She has got perforation of the viscous, and then this patient may having so many problems and after needs to be taken for surgery, and this patient may need a ITU bed. That's why am I calling to ITU register Dr. so and so. When the question answer comes from that side, yes, go on, then if the doctor confirms that the ITU register, then you say the situation you are told, the background. Now you say the short history, the Miss Linda Smith, who had been admitted to the hospital, investigations are done, and date of admission, current diagnosis is perforation viscous, but along with the past medical histories is COPD, diabetes mellitus, hypertension, on so medicines, having allergy to these medicines, blood investigations has done this is hemoglobin is like this, then metabolic acidosis or something. Then this patients have been reviewed by our consultant and the doctors, and patient is supposed to be taken for the operation theater for perforated viscous, and your opinion is required before, and that this patient after doing surgery may require the intensive care unit as the patient having respiratory compromise and all that. So this was the situation, this is the background, and assessment is done. They may ask the questions, have you done this, and then the x-rays, then this. Yes, the assessment is done, how is the urine output, what are the vitals, what the blood investigations. This has to be just taken into from the case paper. You have to note down this. So what are the important things which are to be noted from the case papers? The case papers may have 8 pages, 10 pages, 12 pages. So in fast we have got 9 minutes to read this case paper. First page, what are the important things? The name of the patient is there, which hospital patient is admitted. So I will be demonstrating one after another the different scenarios and the different type of case papers, and where we have to pick up the important things. First of all, who we are and under whom we are working, and which hospital we are working in, and which ward we are calling from, and to whom we are, and the name of the patient, age of the patient, procedure of the patient, admission day of the patient, that is to be taken on the way. Then what are the investigations which is done 2 days back, today, now, and what you are going to do. What are the nursing staff, who is the consultant, now whom you are calling for referral, the name of the doctor, and that. So that is the background. And what will be the response is, then what is the response. So this 9 minutes you are there, and then you have to complete all this and take the important points on your own handwriting. You have got a copy also. If you forget to remember some of the points, you may ask to the consultant. I will go and review it. And if the consultant, have you checked it personally, you have to answer most of the things, no, I will just go and check it afterward, but these are the findings. So let's start with individual cases, and I will be just demonstrating the different case papers, and from these case papers you have to pick up the important points and how to respond.
So the main scenario which we have to pick up is that the basic common stems, around 6 to 7 stems, are post mastectomy. One is post mastectomy. Second one is about oliguria. Then third one is regarding bile leak. Fourth one is about polytrauma. And fifth one is the case of about trauma case. So this is CVTS polytrauma, CVTS referral. Fifth one is trauma case. Just update. And another sixth one is acute limb ischemia. Then the last one most of the time is about perforated viscous and ITU. So which doctor you are calling for which? So this is post mastectomy and bile leak is straightforward. You get a patient, 78-year lady, undergone mastectomy, not medically fit, but COPD with left ventricular failure, fit to discharge. Now, but the doctor is insisting. So this is about a discharge against medical advice. Then here you have to understand that this is a mastectomy and the patient's daughter is taking her home. So you are working under some consultant. Now you are calling to a consultant who is on and updating about this. So this one is one case. So how the stem of oliguria, patient undergone laparotomy, any surgery, maybe hemicolectomy or something, and SHO working for under which doctor, and he is on leave. Now you are calling to on-call consultant, and the nurse has made you to the call that patient has got oliguria. So here this patient has got surgery. Now post-operative oliguria is there. So then the another where the bile leak is, the patient has undergone laparoscopic cholecystectomy maybe 2 days, 3 days back, and this was uneventful, so much blood loss, and then patient has got a drain, maybe put after 1 day, 2 day pain, and then drain is coming around 150 ml or something like that, and you are suspecting severe injury. That's why you are referring to hepatobiliary surgeon. Then polytrauma case, how is this? A motorbike accident, the victim is having unstable, hemodynamically very critical, maybe low blood pressure and everything, but multiple injuries are there. But among that, the very significant part is widened mediastinum. So you are referring for urgent CVTS referral. And trauma case update is again motorbike accident, initially unconscious, RTA initially unconscious, but GCS is on arrival now, but hemodynamically stable, abdomen is soft and patient, but limb is cold, pulseless. So when the limb, so it is update, again it is just like a ALI, acute limb ischemia, but you are just updating it to the trauma head. So this is not referral to the cardiothoracic surgeon. How is acute limb ischemia? This is something patient has been operated for laparotomy or for diverticulitis, Hartmann or any of the procedure, but patient develop atrial fibrillation. Then after that patient develops acute limb ischemia, and here you are expecting vascular surgeon calling to get this patient transferred. Now, further we need to discuss how the picture scenario comes is that a old lady, COPD, steroid, suddenly develops epigastric pain. And in this, you get a pain and everything is there. Classical picture of perforation peritonitis. This patient needs surgery. You are not calling to the surgeon. You are not calling to the any other specialist. Here you are calling to the ITU bed, to the register, that this patient has got so many high risk things like cardiovascular problem, respiratory problem, perforation, old age. Then this patient has to undergo for surgery. Then after surgery, this may require post-operative intensive therapy unit ITU. So you are asking for the bed ITU register for optimization, all that. So how will be the each scenario and how will be the what things you have to pick up from the stem. This one is mastectomy is easier, bile leak is direct case. Then oliguria, here it can be laparotomy or something which may you get confused with acute limb ischemia or trauma case subdural proton, because this specifically for the urine and you are calling on call by the so. Now the three things which you are confused is CVTS referral. CVTS referral is polytrauma, widened stem, urgent referral. Acute limb ischemia, laparotomy was done, it's referred to vascular surgeon. And in trauma case also it is acute limb ischemia, but you are informing to the peripheral discuss ITU register. So let's go with the different case papers and then understand how is the each scenario. First of all, we will see for the mastectomy and try to pick up the important points and fit it into the S bar. Just talking about mastectomy complications. So post mastectomy. Now here, what things you have to note. First case, as soon as it comes, you have to understand Mrs. Janice Green. So the patient's name is Mrs. Janice Green. Now this is the name of the patient. Age is 1940, and if it is 2, so it's around today it will be 86 years. So address is not important. Basically, this is the case number, is that much not significant. This is the GP. General practitioner is P.R. Smith. This is not a surgeon, so this is GP. And he has referred this patient. Now the second thing is same Janice Green, date of birth is female, anytone, address. The date of OPD, this is OP, outpatient note, OP. And it here he was seen by a consultant surgeon. The name of the consultant surgeon is Mr. Mann, and 3 months history of lump and all that. And for biopsy today, that day he has taken 11-10 biopsy, and for left simple mastectomy and sentinel node. Then you get another case, see the date. So date is around 10 days, means this patient was seen on OPD, then 10 days afterward, admission clinic, multi-dimensional team last week, confirmed malignancy has been confirmed, biopsy, drugs, diabetic aspirin, patient is taking these drugs, lives alone in the house, smokes, so this is short history, alcohol and all that, lump breast, OP visit, chest x-ray, has chronic cough. No wheezing, will need anesthetic opinion and get CXA done. Then this 21st, then 27th, after anesthetist has seen the patient, lumpectomy, sentinel biopsy for man, COPD and LVH. Then we'll need high dependency unit post-operative. So next today, operation cancelled today, no time in the theater. Then patient has been on 29, patient was operated on 29. This is the date of operation, So 29, patient was dopeotomy, masonal, frozen section, hemostasis satisfactory, vacuum drain was inserted. So this 30 is post-op day 1. Post-op day 1 is 30, well controlled, drowsy, satisfactory. 31 is post-op day 2 is 31, complete increased discomfort in the axilla, pulse rate regular, slightly shortness of breath, and 90 ml of the blood in training 24 hour, and axilla is puffy. These are the findings. Now report has come, blood investigations. So lab reports show, so pH is normal, PCO2 is little bit raised, PO2 is normal, bicarbonate is normal, O2 saturation is okay, base X is -10. This is the hospital name where the patient is undergoing surgery and all. Janice Green, now understood, the female, and hemoglobin is normal. Result is RBC, everything is okay. You doesn't need WBC count is also normal. There is no infection. Sodium, you see normal. Potassium is also in normal range. Urea is raised. Creatinine is raised. So these are the important findings. So you have to understand. And then plasma glucose. So it's normal. Serum amal is normal. Everything is normal. Then liver, all the lab investigation, LFT, liver profile is also normal. Electrolytes, calcium and phosphate. So this one, this picture of the case paper. So here what you have to identify, you are working in St. Winston Hospital under the consultant, Mr. Mann. This patient has been seen by so many, and then the different one of the source. Patient name, Mrs. Thompson, Eleanor Thompson, 1942, again 60 plus 26, around 86 years, female. Patient is admitted on 2nd April. Consultant is Mr. Mann. Right breast mastectomy with axillary wall clearance. Patient is having significant is COPD, left ventricular failure, hypertension, no allergy. Post-operative day 2. So already it is given day 2. Develop axillary discomfort and swelling with shortness of breath. Patient managed with the standard analgesia. Now, daughter is insisting to take home, which is 60 miles away, and may spend 20 minutes trying to convince, but he is without result. Surgery is okay. Doctor proceeded to patient discharge today is preferable. Patient expenses. So all vitals, admission, temperature, everything, heart rate stable. And this 3rd April, patient undergoes surgery on. You can see surgery has been 2nd April. This is 2nd April surgery admission, 3rd April post-op day 1. This is post-op day 2. So there is swelling and shortness of breath. General oriented, heart sounds normal. Crepitus, no. Surgical site clean, minimal serovenous fluid. 900 fresh blood is seen. So day 4th, WBC count, everything normal. Operative notes, general anesthesia, invasive carcinoma, everything is done. Post-operative mastectomy patient bad axillary swelling, discomfort, clinically stable. So now what is the situation? Here you have to understand your name, location, the hospital name is. You have to pick up yourself in which hospital this patient has undergone. See the name, patient's note, admission, surgery, mastectomy, and then you pick this patient's indications. Breast surgery was done, surgeon was general anesthesia, anesthetist Mr. Mann, then indications, all this is done. Situation is, assessment is post data, clinically stable, high risk for early discharge. So situation is even there. I'm Dr. So-and-so calling from here, Mr. Mann. Am I calling to Mr. Mann? Because he is the consultant. Already he has operated this patient. Even I'm giving the information that 28-year lady who has undergone surgery under right mastectomy, axillary clear, now complaining with shortness of breath and axillary swelling. Now this is the situation. Now background is the patient is maybe short. Patient COPD, left ventricular failure, admitted 2 days ago. Mastectomy has been done. She is pressurized by the daughter, who lives 60 miles away, seems to be convinced by the daughter and prefers to go home, but her daughter is working and now don't take care. So what is the situation, background, and your assessment is that relevant examination findings, positive or negative. She looks anxious, shortness of breath is there, respiration is 20, and basal crepitations are also there, and then axilla is swollen and there is 90. So this is your assessment. Now what you recommend? So examiner will commonly interrupt and may ask many things. Mr. Mann, what do you think? What happened with her? She thinks that axillary swelling, maybe intraoperative bleeding, axillary vein, or some vasculature. So recommendation is that I will speak in this section. You formulate your suggestion to a management plan because you are trying to convince that patient does not should not go to the home, and this patient is insist for living, and instructions that even if this patient goes home, there should be no one to monitor, and then hematoma may increase. How to take care? Patient may develop DVT and CT. So if the patient is on discharge, the formal process that you will go is you have to again explain the things and what is the safety nets and what are the things. So this is the case paper. Just I was trying to make under whom you are working, then under your consultant and patient's name, age, surgery, post-operative day, mastectomy was done, and doctor is insisting to take patient against discharge against medical advice. So you understood the situation. There is patient is having COPD, left ventricular failure. So this is a patient who feel second post-operative day. This patient may require. So when you call, you are making call to consultant. So how will be the call? Hello, myself, hello. So if the consultant's name is Dr. Thompson or something like that, then you call, hello, Dr. Thompson, this is Dr. Hamid. I'm on call as SHO in the surgical ward. I'm calling regarding any name of the patient, Miss Elizabeth Carter, who had undergone 67-year-old, underwent mastectomy and axillary clearance 3 days ago. Her doctor is requesting to take her home against medical advice, and I have concern regarding her fitness for discharge. So this patient cannot be discharged. So the consultant replies that, okay, tell me what about her current status. So we have to say that she is ongoing axillary swelling, which has normal during the surgery was uneventful, but swelling, and there is a fluid collection in the drain, which is about 90 or 150 ml in last 24 hours, and background of COPD and experiencing shortness of breath. And she is on aspirin, which has increased risk of bleeding also. So then he says, the consultant says, okay, so I agree that this patient's daughter is insisting. She says she wants a mother to be in the familiar environment. That's why she don't believe to stay in the hospital, and she's concerned about a mother discomfort. So the question they may ask that her daughter been informed about the risk? Then you have to reply, yes, I explained the risk of hematoma, seroma, seroma, and then potential infection. These are the local complications which may happen if the patient is taken home. Apart from that, the patient may have COPD or respiratory distress and all that. Then about the issues of cardiovascular respiratory, then has the patient made her mind or she has been pressurized? So we can say that doctor is making her mind, and then she had to discuss the risk. Yes, she is competent. Whether the patient is competent means we ask whether she is conscious to understand the situation and give her statement. Yes, in the view of then what is your assessment? So this is in the view of fresh blood in the drain. I think there's possibility of reactionary hemorrhage at dawn, and I have to consider presence of DVT, pulmonary embolism because of shortness of breath. And what are the causes of bleeding? What can be the bleeding? So cause of bleeding can be because patient on anticoagulant or aspirin, so that may be the cause of bleeding. So what can be the cause of shortness of breath? So it may be because of some of the drugs, so maybe pulmonary embolism, COPD, or atelectasis, heart failure. Then axillary swelling. Why there is axillary swelling? Why the patient is having swelling? It is because of hematoma, or can be lymphedema or axillary vein thrombosis, bleeding. What can be your plan of action? So what you will do? Plan of action. So in this we have to evacuate, investigate and evacuate. Then only hematoma has to be evacuated and support axillary vein thrombosis, pulmonary embolism. You have to start, manage accordingly. Then right, have you offered any alternative therapy? I suggested monitoring for 24 hours to release the drain and output and all that. So next question can be, have you involved senior nursings? Have you involved senior nursing person? Yes, the ward sister and everyone has spoken, but you have you documented. So have you documented? So means whether you have done documentation. Yes, I have recorded everything. Have you explained the discharge against medical advice? The papers need to be signed. Yes, I have explained the discharge. I will inform the patient's doctor about the possible complications. So what are the advices regarding safety net? Safety net have you given? So what you will tell, how to look after the drain and when to attend immediately and all that. I will inform the patient's doctor about the possible complications may occur regarding discharge, especially because of she lives more than 50 miles away. So once you have finished this, what about the drain? If a drain has to be kept, so the phone disconnects and you have to say thank you. Case papers showing bile leak. So again here you have to remember the name of the patient, date of age of the patient, name, age, then referred by general practitioner. Then this is the consultant again. Who is the consultant? Is Mr. Man. This is OP notes 14 to 21. Female patient, upper quadrant pain, calculus cholecystitis. So consultant surgeon is Dr. Man. Now you are working under Dr. Man, who has checked this patient. This patient was examined pre-admission clinic, then smoking history is there, alcohol history, drug history, aspirin, beta blockers. These are the drugs patient is under, and then needs general anesthesia consultation, opinion from the anesthetists. So anesthetists are checking post for PSS note. It's posted by man's list tomorrow, smoking, alcohol, drug history, aspirin, beta blocker. So patient is having COPD with prominent hilar. The investigation, this is surgery, 27th. Patient was operated on 27th. Then operating notes, what is laparoscopic cholecystomy? Hemostasis surgery, clippage of cystic duct was done, drain was already put. So drain was put, and this now, this patient has 27, this is day 1, post of day 1, it's all okay, drain is clear. Then post-op day 4. So this is post-op day 4. Patient's on surgery, but drain is bilious content. So abdomen is lax, general abdominal pain needs register view. Then register, everyone has seen the patient. Now patient has to be need for ERCP, but ERCP is not available in the hospital. So refer to the specialist. Name of the specialist is Rob Wallace. So Rob Wallace is a hepatobiliary surgeon in the any share hospital. So now you are calling as a SHO under a man who has been undergone this operative, and may I talking to this Rob Wallace. In this case, it will be like this. Now investigations, this is important. PS, so patient is having acidosis that can be leak by leak, peritonitis, you are suspecting, and rest of the investigation. Important thing is WBC count. You have to remember this is again raised. Then sodium, potassium, electrolytes. If you see urea, creatinine is also, urea is increasing, amylase, CRP, it's okay. Then as you see albumin, alkaline phosphatase, AST, bilirubin is increased. Total protein is also raised, calcium, none this. So these are the investigations you have to keep in mind. So once you get this type of a case where you have just noted, you are calling to doctor. Here the referring to hepatobiliary surgeon. You understood this patient. Now you just pick up the phone, ring to the doctor. I'm calling Dr. Hamid, SHO from Underman, and the hospital. The name of the hospital has to be picked from here in the first page. Consultant surgeon, here the hospital, any share hospital. So this is the sum. So name of the patient is Sarah Marks, of around 66-year-old female who had undergone cholecystectomy, and now the patient is having a bile leak. Am I speaking to Rovales, the hepatobiliary surgeon? He says, okay, yes. Now, then I'm calling to speak to hepatobiliary surgeon regarding the patient we would like to refer. And can I confirm I'm speaking to Mr. Rovales? Yes, this is Rovales. Thank you. I would like to refer a patient, Miss so and so, and 50 undergone interval gallbladder removal 2 days, 4 days ago, but she was well. What's the concern? She has developed worsening abdominal pain since today, and we notice a bile in the drain fluid, and she is having abdominal pain. And after that, any investigations, we have got raised serum bilirubin, raised WBC count and CRP. What is a fluid in abdomen, and we suspect bile leak due to CBD injury. Is she stable? Yes, she is currently stable, and we have started antibiotics and whatever. And Mr. Mann has reviewed, and she has asked to refer it to the hepatobiliary surgeon. So, if the beds are the beds available, are beds available? You have to just inquire. No, the beds are not available. I'm just trying to make it available. So, thank you very much, Mr. Valles. I will send everything. So, please let me know the beds are available. I will keep you informed. Thanks again. Then there will be the questions why there can be leak. The examiner can ask why cystic duct stump leakage may be due to slippage of the clips, then CBD stone, CBD injury, and all that. So, did you do ERCP and WBC count? Yes, it's rare. What is CRP? It's acute phase protein due to surgery and decreasing patient symptoms. So, what about the what blood investigations are done? So, if you have checked it, you can say it, or otherwise, I apologize. I will just go into it. Then, what have you done it now? So, I will start IV fluids, antibiotics, and look for the drain, and then keep need ERCP. Why you want to refer ERCP, endoscopy reticulocholangioppancreatography? What you will do? So X-ray examination of CBD and pancreatic duct involve passing flexible telescope from the oral mouth. Then it is in the, so if what can be done? It has to be done. Stenting has to be done. Biliary anastomosis can be done. So what do you suspect? Is the patient is urgent? Yes, peritonitis due to bile leak in the peritoneal cavity. It may be caused of gallbladder perforation or anything. So now, again, okay, refer the patient and thank the refer this patient to cardiothoracic surgeon. Here, what you get is that a patient's name. Again, you have to go for name of the patient, the title, first name, then the date of birth. In 90 means around 36 year. Then you need to note down the history, like 12:21 at 10 a.m. emergency young athlete motorbike accident 2 hours ago. So it means this patient was admitted, and patient is diabetic, dyspneic, left swollen thigh. So there is thigh injury also. Pulse is 100, BP is 120, respiratory this much. Chest for chest X-ray, CT scan is out of service. Chest X-ray, CT scan machine is not available. Consultant is Mr. Mann. Now under Mr. Mann, the patient name is Adam, around 36 year, road traffic accident, admitted 2 hours ago. So this patient is having history of smoking, pulse becomes, so after 12, 10:30, so 11, within half an hour, pulse rate has increased a lot, BP has gone down, respiratory rate has increased, and chest X-ray has shown widened mediastinum bilateral hemothorax. So this is 11:20, then patient is getting worse, condition is getting chest tube is put inside and 200 ml blood is there. Resuscitation with the 4 liters IV fluids is given, 6 units of blood is given, and X-ray abdomen shadow absent, lower limb fracture. So this is again injury. This one is injury. This one is polytrauma patient. But this is significant finding. Referral to CVT surgeon. There is Danis Wing, cardiothoracic surgeon, Danny Wings. So here you are referring man under which whom you are working, patient's name of the patient, Adam, 36-year, road traffic accident. Chest X-ray, widened, CT not working, and rest of the investigations, hemoglobin has gone down, hematocrit. Okay, then pH is again acidosis, electrolytes, urea, creatinine. Okay, so rest of the investigations. This starts once you ring the bell for a phone call. You start with, means you want a conversation with the cardiothoracic surgeon. So name of the cardiothoracic surgeon, you have to keep in mind, note down that cardiothoracic surgeon's name. This is Dennis Wink. And name you are working under. So hello, I'm Dr. Hamid, I'm working under Dr. Mann. Am I speaking to Mr. Dennis Wink? If he says yes, so from which hospital I'm speaking, so name of the hospital, Adam Stinson, patient's name is Adam, in any town, any share hospital. Yes, Dennis Wing, I'm cardiothoracic, yes, go ahead. So the question is this, why the polytrauma patient? So behalf of Mr. Mann regarding a trauma case, am I speaking to this? Then what are your main concerns? We have polytrauma patient, and following high-speed motor accident, he was wearing a protective gear. This patient is having high-speed motor bike accident and wearing a protective gear, but sustained a significant thoracic injury and also diabetic. So what's the current status? The question is, what's the current status from the other side? So chest X-ray has shown a widened mediastinum, suspicion of major vascular injury, possibly aortic disruption. We are suspecting aortic disruption, and also multiple fracture rates, chest instability, oxygen saturation is borderline. So the question comes from the other side. Has the airway been secured? He is hemodynamically unstable despite fluid restoration. Blood glucose is managed and fast is negative for any effusion or something. CT thorax is pending as machine is not working. Then the question is understood. Please arrange for the urgent transfer. So not yet. Have you intubated the patient? So not yet. Anesthetic is going to do it. So seen all the imaging. So yes, I will do it. Chest X-ray is done and trauma at my administration. Expect time of arrival. How much time it will take? It may take to around, you say, 15 to 20 minutes. And how will you refer it? Patient air ambulance, that has to be there. But what do you do for the cervical spine? You have to put a hard collar bag. Then do you think patient in shock? Yes. What type of shock is hypovolemic or cardiogenic shock? Then you have to think of. The question comes that what do you do for the leg, because patient has got leg injury also. You have to put a splint, and then for abdominal surgery, then surgeon has to be informed. What fluid restriction? Patient has given blood transfusions, 4 units of blood transfusions, and 4 liters, 6 units of blood transfusion, 4 liters of the IV fluids are being given. So what is the closed fracture compartment syndrome? Why there can be metabolic acidosis? pH has got, so there can be compartment pH is less, so metabolic acidosis. And what type of shock is hemorrhagic shock? What other investigation? Echocardio, echo, ECG, and then CT trauma, head and chest. So what about abdomen? Abdomen investigation, absence short shadow. So you are suspecting free fluid in the abdomen, then patient may require laparotomy. So who will accompany the case? The patient, anesthetist and I will be accompanying. So mediastinal widening is there, cardiac tamponade, aortic rupture. So differential diagnosis, there can be cardiac tamponade, aortic disruption, or there can be traumatic rupture. So what will you prepare in the ambulance? So what you think you are going to bring into? Oxygen has to be there, CPR set has to be there, IV fluids, extra chest tube has to be there, blood transfusion, and then who will be intubation? Anesthetist will be doing rupture of the. So what is the source of bleeding? Source may be rupture great vessels. So why there is obstructive cardiogenic? So chest tube is already put. Why there is only 200 ml? So chest tube is put in the pleura, and this is in the mediastinum. Great vessels are in the mediastinum. Oliguria. So in this patient, when you get a sheet, here is the name of the patient, ID, male, 1966, means 34 plus 26, around 60 years male. So this is the address. So the name of the patient is ID male, 60 years, who has been referred from the GP, and this is the date, 12/8/25. Male presented with bleeding prorectum, abdominal examination, weight loss is there, GB is contracted, no abdominal report significant. Colonoscopy CT contrast was done. This patient colonoscopy is circumferential thickening right ascending colon, means this patient of malignancy. So this patient coronary gas distension, means there is obstruction. Now this patient is operated on 16/8/23. So what happened? There's colonic mass, hemicolectomy was done, some blood loss, drain was put, 2 units blood, 2 units of blood is given, hemoglobin is 12. So now this is a patient is operated on 16, midline incision, and this 17:02 p.m. post-operative. You see this abdominal urine output at 6 a.m. was 120, but now from 6 a.m. to 2 p.m. So this time it has gone from 8 hours. So 8 hours, only one in 24 hours, only 1 liters of IV fluid was given. So this is one thing. Then you see pH is down, then oxygen okay, bicarbonates are okay, saturation base axis plus. Now hemoglobin is also low, WC count normal, sodium, you see sodium, potassium is normal, urea is raised, creatinine is raised. So these are the 2 things which are raised. Urea, creatinine is raised, and if you see sodium, potassium, again this is normal. So albumin is not significant. So what you see in this patient, how to now you get a patient, post-operative urine output is very low. Now you just pick up a phone, you have got 9 minutes to read this and pick up a phone and make up your mind that what things you are going to understand. Yourself, first of all yourself, Dr. SHO under man, and the hospital's name of the hospital is consultant surgeon is man. So if the hospital name is not given, it's okay. Patient's name I'm calling to. Patient's name is Eddie Raymond, 60 years, male. Eddie Raymond's 60-year male, calling to consultant. Now you are calling to consultant. So you pick up the phone and say that, hello, myself Dr. Hamid, one of the surgical doctors here, and working with Dr. Mann, and just I want to inform about a patient named Eddie Raymond, 60 years male, who had undergone hemicolectomy yesterday, and we are worried about the patient urinary output. Am I calling to consultant Mr. Mann is on the loo or something like that, and speaking to on-call consultant? If you get yes, speaking, I want an advice about a patient who went under open colectomy and then he has been oliguric now. Summarize your case. The patient named Eddie Raymond, 60 years male, who has undergone a surgery yesterday, and he's no diabetic and hypertension on so and so medicines and mild prior to operation, but stable now. Urine output is of around 20 ml. Intraoperative blood loss was very few, and there are 2 results of blood transfusion. What is current blood pressure? It's current blood pressure. When you see the findings, you have to note that respiratory rate BP is low, respiratory rate is high, 95/56, respiratory rate is 102, temperature is. So urine output has gone down. Then have you done the investigations? So blood pressure is 95 by 56, heart rate is pulse rate is 102, and temperature is raised. Abdominal X-ray is normal, urine output has gone down. So fluid chart shows that only 1 liter of fluid was given. So investigation shows increased blood urea and creatinine. What is, have you done the fluid challenge? So have you done the fluid challenge? Not yet. I was thinking to give 500 ml of fluids 4 times. Okay, then check his bladder. No obvious sign, he dropped hemoglobin. So hemoglobin was initially, pH is acidosis, and hemoglobin has gone to 10. So now what you will do, he has dropped from this 13 initially, now he is hypertensive, agreed. Good, let's proceed with the fluid challenge, agreed. I will keep up updated and inform nursing team to monitor urine output. I will tell you and know the condition if deteriorates. So you get a message from the consultant that consider for night if he is remaining oliguric. Okay, call ends. Thank you. So I will update the patient. Then you get a questions that I think patient is, why the patient is having low blood pressure. He is dehydrated and receives only 1 liter of Hartmann solution in more than say 24 hours. So this is needs more fluids. What do you think the cause is? Checking operative notes and he has some blood loss, but he received 2 blood transfusions. This can be dehydration. Why? Creatinine is high because of fluid. Creatinine blood urea is high because the patient is having dehydration. So fluid challenge will. Then what is your plan? So fluid challenge about 5 liters, 500 ml, and then 500 ml ringer lactate substitute 4 times you have to challenge, then measure the urine output. So checking operative notes, then continue monitoring the ward. What you will do then, if patient doesn't respond, I will transfers to high dependency unit, inform HDU register, insert central catheter, and monitoring repeat blood tomorrow and hemoglobin. How will you monitor, assess the vital signs? Fluid challenge, no, but monitor signs. Do you think patient is bleeding? If patient is bleeding inside, abdomen has to be distension, peritoneum has to be there. So bleed, let us know. So you have to measure, monitor capillary filling, BP. How do you know? So measure capillary filling, refill time, blood pressure, urine output, and mental status and hemoglobin. These are the things which you will monitor. Do you think there is anastomosis leak? If abdomen is soft, there is no leak, and don't suspect. Do you want me to come? I will start fluid challenge. Then check the patient whether patient can be having increased urine output. Does he need HDU transfer? No, if improvement is not there. And fluid challenge again, I will talk to HDU and transfer. So does he require operation? May require, that depends upon the fluid challenge. So what is the indication for hemodialysis? Hemodialysis, it has to be done if severe acidosis, pH is less than 7.2 and persistent potassium is more than 6. If this is the case, you have to go for hemodialysis. Hypovolemia and can be. What is the normal urine output? It has to be 20. Fluid challenge has to be 20 ml per kg. So it has to be 1.5 ml per minute. So urine output. Thank you. Now let's go for the station where the patient is having vascular injury and you need to update a trauma case. So here is the case paper. You get the name of the patient, age of the patient, and then address, and referred from the GP surgery to the hospital. Who is working consultant is Dr. Mann, and this is Edward Ray, name and address. Then this patient is admitted in emergency with left leg wound and tenderness. Distal pulses are absent. Right side pulse are normal. Blood pressure and everything is very normal. Consultant is Mann. So what you are going to, you have done the X-ray, the STP fibular fracture, multiple fracture. So this patient is having vascular injury. So fracture both bone, evidence of vascular injury, refer to the vascular surgical hospital. Now this consultant, he has told that this patient needs referral. Now you are informing a trauma head about this patient. So not to the CVTS surgeon. Since this has to be, then the investigations, pH is low, hemoglobin has gone down, urea creatinine is raised. So this patient is, so how it can be. So when you see the station is, so when you pick up the phone, hello, I'm Dr. Hamid, I'm working under surgeon Mar from the hospital. I just want to inform about a trauma patient. I want to update this. Am I speaking to trauma head? So this patient has got, yes, go ahead. So this patient has got a motor bike accident. He is hemodynamic stable. And initially GCS was so, abdomen is so, and there is an open leg fracture, but now cold pulseless limb. So all the investigations apart from race CEP, WBC, X-ray open tibia fractures. So what you see here given the IV fluids, the prophylaxis and trauma head, I am just updating it. So this patient may be having, now the question and answers will be, this patient is having open fracture, tibia, fibula, pulseless foot and abdominal collection. So the stem is motorbike, blood investigation are normal. So right tibia, antibiotics given. So this has to mention summary and so on, abrasions and all that, tetanus antibiotics, trauma consultant. So, okay, hello, I'm speaking to Mr. Wand, update the case, yes, summarize your case. 21-year male, examination, he was stable. What is most urgent? The patient is having open fracture with arterial damage. And now urgent in a ischemic compartment syndrome. Is the patient is wearing collar? Yes. Information is not given in the notes. I will definitely check. What is the cause of pulseless foot? That can be vascular injury or a compartment syndrome, kinking or arterial spasm. Is the patient dehydrated? Information not given. IV fluids, how many I am not sure. And then, so what is the investigation? Duplex ultrasound. Plan of action. Summarize at the end. I will inform the orthopedic surgeon, vascular consultant. I will reduce and immobilize the fracture. CT scan, head trauma. What to do before sending him to the theater? IV fluids, analgesics, traction, anti-tetanus, antibiotic, cover the wound. So what will we do? Why will we do for the wound? Debridement for the necrotic tissue within 24 hours in operation at risk. So what blood investigation? Complete blood, RFT, LFT, blood grouping, cross matching. Why are you calling me now? Need overnight surgery. How to fix his fracture? External fixation. Open fractures, antibiotic, combined vascular injury within 3 to 4 hours has to be done. Compartment symptom has to be done. Cover the wound with the debridement. So initial stabilization, soft tissue and bone polytrauma, damage control, orthopedics, access, then bony continuity and why does GS general surgeon ask for ultrasound when they felt abdomen is normal? So abrasions can be possibly of injury. People I may need to call either in pre or post-operative operation theatre, anesthesia, general surgeon, vascular, plastic, neurosurgeon and orthopedic. Why plastic graft for the open fractures? Why general surgeon, open wound, compartment syndrome, intra-abdominal injury, management of the free fluids in abdomen, emergency laparotomy.
So the another situation which you get a patient having 73-year-old lady, COPD on steroids, suddenly develops epigastric pain, suspected perforated viscous, patient's laparotomy, your SHO forman, call ITU register, request to advise preoperative optimization. So patient file contains the patient's name, then what are the conditions, COPD, presented for emergency, generalized abdominal pain omitting, rigid abdomen, chest x-ray, gas in the diaphragm, perforated viscous, prepare for laparotomy, past history, COPD, type 2 diabetes, hypertension, GERD. Then you get medications patient is getting is salbutamol, metformin, ramipril, omeprazole, vitals and everything. So here you note down the patient's name and everything. Then you need to call to ITU phone. Hello, I'm Dr. Hamid, working under Dr. Man. Want to discuss a patient potential for ITU admission. Am I speaking to ITU register? Yes, speaking. Yes. What is the condition? So then why you are suspecting sepsis? So this patient has got WBT count increase lactate, distended abdomen, blood pressure. So what are you suspecting? Kidney functions are acute kidney injury, creatinine is raised, urea is raised, electrolyte is hyponatremia. So ABG findings, what are the ABG findings? Any concern about CVD? ABG is 7.3, PCVT is normal, retention chronic, respiratory acidosis, may require ventilatory support. Yes, may require ventilatory support. So do you difficult extubation? Yes, urgent laparotomy is required. This patient may leak. So what are the other questions? What are the drugs for COPD? Patient was taking steroids and induction 100 milligram hydrocortisone will be given preoperatively for ECG, atrial fibrillation, and fluids. Resuscitation of the fluids 1 to 1.5 liters urine after output after catheterization. How to monitor fluids? Then you measure that heart rate, BP, capillary refilling, urine mental status. Do you insert catheter? Sorry, if you're not sure about that, then you have to put it. When will you contact beside me? Anesthetic and the surgeon. Patient had COPD. What is SpO2? Any you are going to give ventilation, must be nasal oxygen, all that. Avoid respiratory depression, hypoxic drive. Will you respond? You repeat yes. Antibiotics, culture sensitivity. If bed is not available, if the patient is deteriorating, what you will do? Blood group and cross matching and treatment for atrial fibrillation, correct electrolytes. Patient need I2 admission, COPD, mechanism, renal failure. More than 2 systems, renal as well as lungs are failed. That's why patient requires ITU. If bed is not available, continue monitoring in the recovery. If surgery is risky, yes, but it's urgent. So these are the things for perforated viscous. So here you get a case of acute limb ischemia. How it can be there in this 67-year-old John Smith admitted with abdominal pain, initially diagnosed as diverticulitis, symptoms were improving, suddenly developed severe pain right lower leg responding to analgesic. UR was situated under James Cook's Hospital, called to vascular consultant and transfer the patient. So the candidate is calling to a consultant. So how you go through all the case paper, then immediately you pick up the phone and say, hello, this is Dr. Alex Carter, surgical trainee, and the hospital. I need to refer a patient suspected of acute limb ischemia. Is this good time? Yes, I am speaking. Doctor, go ahead. So sure, Mr. John Smith, 67-year male, presented with 6 hours sudden onset of severe limb pain and coldness and weakness, no history of trauma. So got it. What exactly examination and findings? So you see that right lower limb is pale, cold, absent pulses and palpation, capillary refill is delayed, and there is mild motor weakness, sensory loss below the knee, Doppler. So any back history of risk factors. This patient is known peripheral vascular diabetes, hypertension, hyperlipidemia, and he has got CABG for last time, and smoker, and ECG shows atrial fibrillation, which might be the embolic cause. Okay, what investigation has been done? Blood investigation shows hemoglobin 13 point, WBC count normal, all the other count normal, HbA1c 7.8, lipid profile cholesterol, ABG is normal, lactate is Doppler confirms atrial occlusion, ECG shows atrial fibrillation. So what treatment received so far? We have started IV heparin bolus followed by infusion. He is on oxygen with analgesia, limb is elevated and kept warm, and so irreversible ischemia yet. Good, the patient is likely to be embolus, acute limb ischemia. We need urgent CT angiography. If there is no irreversible ischemia, we will likely to proceed for embolectomy or thrombolysis. So I will arrange CT angiography urgently. Anything else? So now to monitor for the deterioration, motor loss, increased lactate. So what are the other things? So other questions that will come are, can't it wait until tomorrow? No, patient had critical limb ischemia. Why do you suspect acute limb ischemia? Clinical feature, pulseless, pallor, pain, ECG, atrial fibrillation, embolism. So then what? Do you need cardiology review? Premature? No, this can be done afterward. Likely cause of arrhythmia, electrolyte disturbances, hypokalemia, time sensitive documentation. Then you have to do ECG, lab absent pulse. What about diverticulitis? In the light of acclimation, atrial fibrillation, consider mesenteric ischemia. Mesenteric ischemia can be the differential diagnosis. Do you need scanning, perforation, preferably after transfer? Could it be a bowel ischemia? Why not save bowel first? Yes, possible. Abdomen is currently soft, so we will do it afterward. Then transfer method. How will you? Air embolus? If not, by this. Imaging required, arterial duplex, CT angiography. Prepare with CPR set, syringe pump, cardioversion, amiodarone, and everything. Then management plan is crisp, then correct decrease, potassium, atrial fibrillation, anticoagulation. Then what else? Why? Fasciotomy for compartment syndrome. Then what is reperfusion injury, revasculation, limb, or that. Management of atrial fibrillation, correct hypokalemia, beta blocker, rhythm control by amiodarone. Then decrease potassium correction, Ksol 20 to 40 in 1 liter saline ECG monitoring. Then serial potassium measurements. Anticoagulation bolus unfractioned heparin 80 internationally, no molecular heparin.